Welcome, colleagues, to this explainer on the clinical diagnosis of leprosy. Go ahead and settle in, because we're preparing for a rigorous, highly detailed examination of what is honestly one of medicine's most historically complex diseases. Today, we aren't just reviewing basic facts. We're refining a precise clinical workflow. Literally every single detail matters here, from the very first question you ask your patient all the way down to the final microscopic evaluation at the bedside. We're going to move deliberately, step by step, making absolutely sure you have the exact frameworks you need for an accurate assessment. Okay, let's dive into this. Our clinical workflow today is divided into 5 critical stages. 1. The patient history. 2. Analyzing presenting complaints. 3. The clinical examination. 4. Evaluating skin and nerves. And 5. Conducting bedside tests. Section 1. The patient history, building the foundation. Long before we even lay a hand on the patient, we have to gather the historical clues. The primary goal of history taking is to establish a diagnosis by excluding other conditions that simulate leprosy. I want to pause and just let that core purpose sink in for a second. We aren't just looking for leprosy. We are systematically ruling out the great imitators. Depending on your region, that might mean leishmaniasis or onchocerciasis. Diagnosis by exclusion is, without a doubt, our first line of defense. Every single piece of demographic data holds real clinical weight. Getting the patient's name builds essential rapport. Age and sex heavily guide our epidemiological expectations. For instance, males generally face more severe disease, while females actually have a higher risk of reactions. But I really want to draw your attention specifically to occupation. Think about it. When you're examining a manual laborer, their peripheral nerves are usually naturally prominent just due to the physical, repetitive nature of their daily work. So you have to exercise extreme care when interpreting nerve enlargement in these patients if there's no actual nerve function impairment. Context is everything here. Section 2. Analyzing presenting complaints, timing and symptoms. Now, what's really interesting about analyzing presenting complaints is how it totally shatters the common misconception that leprosy is strictly a disease of the skin and peripheral nerves. It's not. In lepromatous leprosy or during type 2 reactions, the bacillus can infiltrate multiple organ systems. You've got to ask the specific, targeted questions. Check the eyes. Is there difficulty in closure indicating legophthalmos? Look at the upper respiratory system. Any anosmia or a blocked nose? What about cardiovascular signs like pedal swelling? Even the adrenal glands and the male reproductive system can be heavily affected, leading to things like hypotension, testicular atrophy, and gynecomastia. You absolutely must think systemically. Furthermore, duration is entirely diagnostic. Listen to the patient's timeline carefully. It's a massive clue. Hypopigmented patches that have been present since birth, or maybe lasting only a few days, are highly unlikely to be leprosy. You should probably be thinking of something like nevus depigmentosis instead. Conversely, time is incredibly critical when it comes to neuropathy. Nerve function impairment lasting more than 6 months carries a severe escalating risk of permanent deformities. In this context, time literally equals tissue. Section 3. The clinical examination, head to toe. Moving into physical evaluation, which always needs to happen in adequate daylight, we occasionally encounter a specific physical finding, clinically referred to as the Buddha ear. This presents as sagging, noticeably loose facial skin alongside distinctly enlarged pendulous ear lobules. Now, it's crucial to understand that this specific presentation does not indicate early disease. Rather, it's a classic hallmark of treated lepromatous cases, or patients with long-standing, burnt-out disease. It's a vivid, physical window into the patient's pathological past. Section 4. Evaluating skin and nerves, the core diagnosis. This is the dermatological and neurological focal point of our entire examination, because it directly determines the patient's treatment classification, and our treatment protocols rely on very strict numerical thresholds. Simply put, we classify the disease by counting. Postbacillary disease is defined as having not more than 5 skin lesions and not more than 1 involved nerve. Multibacillary disease is strictly defined as having more than 5 skin lesions or more than 1 involved nerve. I want you to keep these exact numbers locked in your mind. They completely dictate the therapeutic regimen. And this brilliantly illustrates the clinical spectrum of the disease. Let's compare borderline tuberculoid or BT leprosy directly against lepromatous or LL leprosy. With BT leprosy, you'll typically see a large asymmetrical lesion with well-defined margins in certain areas. Contrast that widespread presentation with LL leprosy, where you'll find multiple, small, ill-defined, and widely disseminated symmetrical lesions. It's a fantastic rule of thumb. Asymmetry points toward the tuberculoid pole, while widespread symmetry points firmly toward the lepromatous pole. Then, we have the distinctive plaques found in mid-borderline, or BB leprosy. This morphological sign is widely known as the Swiss cheese appearance. It features these fascinating inverted saucer-shaped, punched-out lesions. What's truly remarkable here is the well-defined inner border sloping outward, which ends up leaving islands of completely normal-looking skin trapped entirely within the plaque itself. It is highly specific, and once you know what to look for, you won't miss it. Of course, sensation testing requires absolute precision. Following the WHO-recommended sensory testing sites on the palmar and plantar surfaces is essential. When testing, you must always use a trial method with a patient's eyes open first, just to make sure they understand the feeling. Then, test from the uninvolved area, moving slowly toward the involved area. And remember the permissible limits of misreference. On the hands, a patient might misreference by up to 1 centimeter. On the face, it's 2 centimeters, and on the back, they can be off by up to 7 centimeters. A failure of proper sensory testing ultimately leads to severe complications, like a plantar trophic ulcer. The sites of predilection for these are almost always areas of high pressure, most notably the head of the first metatarsal, the heel, or the lateral border of the foot. When examining these ulcers, you've got to aggressively look for evidence of secondary bacterial infections. We're talking foul smells or dirty slough. A constant discharge of pus, especially despite adequate wound care, is a massive red flag. It strongly indicates the involvement of deeper structures like tendons, joint capsules, or even bone. Section 5. Conducting bedside tests. Objective confirmation. Let's move to and see how this builds into our laboratory confirmation. The slit skin smear is arguably our most valuable tool at the bedside, but the technique has to be flawless. Follow these steps exactly. Step 1. Clean the lesion and grip the tissue firmly between your thumb and forefinger to render it avascular. Step 2. Make an incision exactly 5 millimeters long and 3 millimeters deep with a small scalpel. Step 3. Turn the blade at a right angle and aggressively scrape the cut surface several times. Step 4. Smear that collected tissue fluid right onto a glass slide. And finally, Step 5. Fix the smear over a flame before applying the Ziehl-Neelsen stain. Listen, if your cut isn't deep enough, you will miss the granuloma entirely. Once it's appropriately stained, we grade the smear under oil immersion. We rely on Ridley's logarithmic scale to measure the bacterial index, which is the density of both living and dead bacilli. It ranges from a 1+, meaning we're seeing 1 to 10 bacilli across 100 fields, all the way up to a 6+, which means we're seeing many clumps in just an average field. We also have to calculate the morphological index. That's the percentage of solid, uniformly stained bacilli. To actually be counted as solid, the organism has to meet strict criteria: uniformly stained, parallel longitudinal sides, rounded ends, and the length must be exactly 5 times its width. This specific index is crucial because it tells us if the treatment is actively killing the bacteria. Finally, we have the histamine test, which we use to specifically evaluate autonomic nerve function. You see, Mycobacterium leprae uniquely parasitizes Schwann cells. This causes perineural inflammation that essentially knocks out the sympathetic nerves supplying the skin's blood vessels. To test for this broken reflex, 1. Place 1 drop of histamine on normal skin and another on the suspected patch. 2. Prick through both drops deep enough to penetrate the epidermis. 3. Wipe it away and wait exactly 5 minutes. 4. Normal skin is going to show a wheal, surrounded by a distinct 2-centimeter vascular flare. But in leprosy-affected skin, because that autonomic reflex is totally broken, that vascular flare is going to be entirely absent. We have systematically walked through the history, the physical, and the complex bedside diagnostics of this disease. As clinical practitioners, the heavy burden of accuracy rests squarely upon us. A single missed sensory cue or a sloppily executed skin smear can literally result in a lifetime of completely preventable deformity for your patient. So I'm going to leave you with this imperative question to mull over. If a single missed sensory cue can alter a patient's life, how will you refine your clinical workflow tomorrow? Thank you for your rigorous attention during this explainer.